Top Bed Talk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on Top Bed Talk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Nick Majerison here. This piece was recorded at last year's 21st Current Controversies in Anaesthesia and Perioperative Medicine and SIAA Autumn Congress at the DINGLE Skellig Hotel in Ireland. Have a listen.
It's a pleasure to introduce our next speaker, Brian Marsh. Brian's a consultant in intensive care and anaesthesia at the Mater Hospital. He didn't really want me to say anything about him, but for those of you who don't know, I will say that Brian has been a leading and at the centre of all developments in terms of intensive care medicine, particularly in Ireland, but also at a European level over the last 25 years. And Brian is going to talk to us about critical care for the very elderly patient.
Good afternoon to you all, and thank you for inviting me to speak. I work in the Mater Hospital, which, just out of interest, is at the top of O'Connell Street, the busiest part of Dublin, so that's where we placed our National Isolation Unit. And again, just as a kind of a declaration of conflicts of interest, I'd have to say that most of the work I'm going to present to you now is not my own. It is informed by this excellent series of talks, including one of our august speakers here today, from earlier on this year, which was excellent at the college meeting in Croke Park earlier on this year. There's some very good sessions in Berlin looking at the role and the future of our care for the elderly, some of which I'm going to talk to you about as well. There's the VIP studies, which hopefully some of you have engaged in. Certainly for Ireland, there's reasonable engagement, particularly in VIP 1. VIP 2 just complete and due to publish. Some of you will have seen some of the preliminary data already. And again, it's very interesting stuff. And all these materials focus particularly on the elderly above the age of 80, which is a bit of a difficulty because a lot of studies take 65 plus as an age threshold, so we're starting to mix and match data, which makes interpretation a bit difficult. And of course, I've shown some of these before as well, that we're looking at a very mixed bag of elderly patients, some of whom are incredibly fit, and some of whom really aren't, like the unfortunate patient number 7 there at the very bottom. And we need to tailor our care to meet these completely different requirements. We all know that the aging population is getting bigger and bigger. We know that our population pyramid is starting to invert itself a little bit, so I'll very soon end up at the top end of that pyramid, and hopefully some people here are young enough to look after me, I hope, as time goes on. If we look at the intensive care impact, this is the Norwegian publication, and the pyramid here, as you can see, shows the preponderance nearly of the elderly patient within their intensive care practices, and that's heading now towards the 15 to 20% mark internationally of patients above the age of 80. And what I've added to it, in fact, to the side of it, is the Mater Hospital shape at this point in time. And we're seeing the same thing. Our average age is going up and up and up. The number of patients, I did a study back in 2002, where I was able to count a grand total of 40 patients above the age of 80 in our ICU and our HDU. Nowadays, I'd count close enough on 160. So times have changed radically over a relatively small number of years. We're seeing cost, of course, and very familiar with this data, I'm sure that so much of our healthcare spend is at the far extremes of life. And the difficulty at the end of the day for all of us is trying to decide how much of that spend is wise, and perhaps even how much that spend is desired by the people that you're spending it on. So there's a lot to think about on this, and it's not something that's ignored by society. This is from the Irish Times during the summer, which published a weekend section completely on the elderly and the impact for Ireland of the ageing population, the impact on our healthcare system, and the impact upon ourselves as younger people supporting the elderly group. So I split down this talk into a series of discussion points, really. I think we need to know what our elderly patients really want. We need to know what the qualities are of our current prognostic tools, and what are our critical care outcomes for the elderly, and how well informed are they. Similarly, is there a referral bias influencing our current outcomes? So in fact, our outcome statements mightn't actually be all that true. Is there a treatment bias similarly affecting our outcome statements? So again, maybe we don't really know what we're talking about. Are we adequately researching elderly-specific critical care and its outcomes? And do we need to adapt our model of care specifically around the elderly? And again, I'd just like to emphasise, I'm thinking very elderly. I'm thinking 80-plus years of age here, because I don't really know. Between 65 and 80 can be a very good period of people's lives. It's very hard to... We need to start stratifying into the very elderly versus the simply geriatric, shall we call them. So we look at what do our elderly patients really want. Again, very difficult, and I've shown this slide of previous talks again on this topic, but I do like it because what it says to me, this study goes back quite a long time, 2002, and it took a bunch of elderly patients aside and said, look, if I offered you an option of a treatment which is going to come up very painful, very high burden to you, but your outcome will either be alive or dead. You won't be cognitively impaired, you won't be functionally impaired, so you either have a very good outcome or you're going to snuff it. And actually, by and large, they'll go with that. They say, that's not so bad. That's not a bad gamble for me. I'll take that option. But if you start introducing confounders into it and say, well, you might be functionally impaired, you might be cognitively impaired, I can't tell you how much, but you're going to carry a bit of a burden after this, they'll start to think a little bit more. They'll start to say, well, maybe that's not quite for me. But in fairness, a large part of the group said, I don't really know. Now, bizarrely enough, I did an interview with this gent here, an 86-year-old man, last year, and I presented a large part of this interview at the AGPI last September, I think it was. And I placed the same series of questions to this guy, very educated guy, good fellow, in pretty good nick, as you can see. And asked him, look, well, what do you think, if I presented you these kind of scenarios? I thought he'd come up with some very good answers, because I know he'd gone through an advanced healthcare planning process. What would you like to do? If it's a 50-50 chance? I was trying to lean on him a little bit and say, well, that's not great, frankly, 50-50. But he was very prompt. He said, look, I'll tell you what, 50-50, I'm not a betting man, but I'd take a 50-50 chance. 86 years of age, on his feet, doing pretty well. On the contrary scenario, though, of if I leave you functionally impaired or cognitively impaired in some kind of way, he said two things. He said, well, I'm not so sure, but you know what, Brian? That's a really easy question for you to ask, but a very hard question for me to answer. And I thought that was very, very fair. We see this also in the ethical study, which is kind of informative as well. It goes from the bottom up nearly, that the elderly patient sees quite clearly that non-invasive ventilation isn't such a big threat and worth a gamble. If you add invasive mechanical ventilation to it, a little less certain, down to about a 50% take rate. But if you add renal replacement therapy on top of that as well, then the proportion that are interested in taking this on go further down. But also very interesting, if you look at the green boxes there, I'll let the physician decide. They really weren't so keen on that. That was kind of interesting to me. What are the qualities of our current prognostic tools and our actual outcomes? Well, I'm only going to pick a few of them, but if you look at our prognostic tools here, this is a slide I think that Hans Flatten put up, which is rather informative, that our prognostic tools were created around different age groups. So the average age of the patients that made up the base to create those Apache 2s, SAPS 2s, etc., were more in their high 50s, early 60s, not patients of the 80-plus year age group. They may be perfectly applicable, but we actually don't really know. They haven't been tested properly against that age population. We do know our outcomes. We do know that the mortality is pretty high, that taking a large cluster of studies, again, this is from Hans Flatten's work from Norway, putting together a significant group of intensive care studies, that the mortality at about 6 months is around about 50%. So that's a reasonably clear statement that we can give to somebody of this age group. Mortality about 50%. We know that elective surgery of whatever age group, if you can walk into the operating theatre, there's a pretty good chance you can walk out of it as well. So elective surgery isn't such a big threat. Emergency surgery, yes, more threatening, but certainly not as bad as an acute medical admission. Acute medical admission into intensive care, a significant threat. There is good work going on frailty scales. This goes back a little bit now, the Rockwood scale. But you're seeing it more and more. I think there's a discussion tomorrow on frailty with regard to elective surgery, I think. But useful because it's easy to do, and work going on, which is where the VIP studies came from, to try and draw a tighter relationship between frailty score and outcomes. So that's going to be helpful. We can see this relationship here for ICU data. The previous one was non-ICU. In fact, I might actually go back to that, because the point I wanted to make on this, if you look at the months along the bottom line of a 70-month follow-up, If I'm 80 years of age, 70 months is an awful long time, and I need to be better informed as to, well, what do you think I'm going to be in 6 months? Tell me what I'll be in a year, maybe tell me what I'll be in 2 years, but beyond 2 years, frankly, I don't care. I'll take my chances. So 70 months is a huge window. This might be tighter and more informative ICU mortalities, hospital mortalities, and 6-month mortalities, but doubling each one more or less for a frailty score greater than 5. And 5 isn't all that high up on the frailty scale, but it's beyond the vulnerable. It's what you would call mildly frail. So then we've got an issue then, how do you work out meaningful outcomes? So survival is kind of easy to do. You just measure it, alive or dead. Functional and cognitive impairment is much more difficult, of course, and it might have different meanings to different people. I might be rather more prepared to carry a little burden than you might be prepared to carry. And it's a very individualistic thing. So prognosticating around it is difficult. And how do we express it to our patients? This kind of work here is helpful. This is an age and retirement study of 1,000+ patients in the United States, and it interviewed patients or people before they became patients during their retirement years. And the bottom two, this pointer doesn't show up very well, but the bottom two here, 0 and 1, the red and the blue, are people who have a very limited number of deficiencies, either no deficiencies in their ADLs or 1 to 2, 1 to 3. And the grey box is the point after they've undergone a period of admission to intensive care for severe sepsis. And patients who had minimal number of deficiencies, or perhaps none, suffered the worst by gaining 1 to 2 new deficiencies after their intensive care stay. The more frail person is a different cohort, really, because they're already very frail, and maybe 1 or 2 more, it pushes them into the terminally ill phase. But to be able to say to our patients, which we can't say really yet because we haven't got enough information, but you have to say to them, look, you'll survive, but you're going to be considerably more dependent in specific ways, that would be very helpful. But I don't think we've got the right information to be able to say that so clearly. I like the statement at the bottom here from the same paper. Sepsis is often a sentinel event in the lives of the older patient. So again, the boxing is the same. On the left-hand side, before the grey box, is pre-event, with about a 5% incidence of significant cognitive impairment. But to the right-hand side, as you look at it, once they've undergone that period of critical care admission for a sepsis event, the rate of severe cognitive impairment goes right up to 15-17%. And that might be very influential if you're discussing it with a patient as to what might happen to them or to their next of kin. Well, what will be the far side of this critical care admission? What about, is there an inherent bias in our current outcomes? So are we all accepting the same kind of patients? And just very quickly, this is the ELDICA study from Charlie Sprung. And as you can see, just running down the boxed area in red that I've highlighted there, that the rate of admissions to all these different intensive care units is completely different. So who's rejecting who's accepting whom, what are the criteria for admission of the patient over the age of 80 years of age? So a very mixed bag. So how then do you compare the outcomes of all these different centres? Very hard to do. And as again, you can see from the same study that the older you get, the more likely it is that you'll be turned down from intensive care. And then this is a Parisian study, which again is very interesting. If you then take that previous thought and you set a few rules, so you take a group of intensive care doctors and emergency department physicians, and you say, okay, let's all agree what patients will be referred to intensive care, and let's see what their outcomes are going to be. So if you just follow down the left-hand side as you look at it, this group had all agreed, this is a Parisian group, all agreed exactly who they would admit to intensive care for this age group. And 1,426 of the patients met those admission criteria. And they're working off an SOP, off a protocol, and they managed to then only refer 30% of them, despite having all agreed that this is exactly what they would do. So only 1/3 were referred. Then the intensive care doctors, they only admitted half of those. So having pre-agreed exactly who they would take up, they then broke all their own rules all the way down through the study. Probably, in fairness, reflecting real life quite nicely. So then it just kind of underlines how difficult it is to be able to give clear prognostic information to our patients. What about, is there a treatment bias? And this goes back to the support study of 1997, when it was more apparent back then that the older you were, you would be offered surgery for just about anything that you needed surgery for, but you were more likely to be refused dialysis or refused mechanical ventilation. Okay. Is that true nowadays? Well, this is work presented by, it's not work of David Memons. We presented it at the Croke Park meeting, which I just picked it up at the time, looking at the TARN data for older people, just making the point that for the elderly, there's plenty of elderly trauma, plenty of severe elderly trauma, ISS of greater than 15, but the doctors who go to see them, the consultants, will migrate towards the younger patient and invest their energy in the younger patient. But for the 90-plus year age group, the consultant is the smaller box at the very bottom, and the younger doc will be directed towards the older patient. They have plenty of head injuries on the left-hand side here, but for the older patient, the time to CT scan is rather longer than that for the younger patient. And in this graph, in fact, the younger patient's only down at 60 to 69 years of age. But there would appear to be some sort of selection process, or maybe not, pushing out the CT scan for the elder patient. Unknown from this, does it make any difference? But what about if you get into one of our intensive care units? Do we treat you differently once you actually arrive in? And I've just picked one study here, because it would seem that maybe we don't. This is high-intensity treatment. Again, a Parisian database. Bottom left-hand corner defining what high intensity is, vasopressors plus mechanical ventilation plus or minus renal replacement therapy. So if you look at the whole bunch of the 80-plus group, are they treated differently? And over on the far side, as you can see, well, no. Once you're in the door, you'll get the same level of treatment. And that's probably fairly consistent with our own experience, I would think. Though I don't think we haven't got the data to prove it, but it feels about right. Put in a bizarre way, this is the American side of the fence. This is the increased number of mechanical ventilation episodes for patients with dementia coming from nursing homes into intensive care unit beds, which has gone up from 39 per 1,000 hospitalizations to 78 per 1,000, with no improvement in mortality. So not necessarily much of a gain there. What about our research? Are we adequately researching what we're doing for our elderly patients? So I have mentioned earlier on the frailty indices. Okay, that's an interesting area of development. And I've mentioned the Rockwood score here, the frailty score, clinical frailty score, which probably most people are familiar with now. This is the rather bleak presentation of the frailty score as it might appear at your bedside, how to identify who's vulnerable and who's mildly frail. Vulnerable there being the score of 4, mildly frail being the 5. 5, in fact, better defined here. This is on the American College of Cardiologists. This is kind of a bit of a fresher looking picture, but the moderately frail being those people who are just starting to acquire some help, which would be very common, of course, but it's not an awful lot of help, just a little bit of help with your instruments of daily living, making telephone conversations, managing your money, that kind of stuff. So mildly frail or moderately frail, it's a soft enough category. But as we saw from the earlier studies, it has a big enough impact in terms of longer-term outcome. This is the VIP1 study, and again, just to thank everybody from the Irish network who supported us in getting Irish centres into this, but it was a large database. The English contribution, or British contribution, was huge, in fact. 311 ICUs across 21 European countries, more than 5,000 patients, mean age of 84 plus, Irish participating hospitals, but this is the bit to pick up on. At a pre-frailty of 5 to 9, you suddenly see the ICU survival going from 79.7 down to 73%. So that breakpoint of 5 seems to be very important. 30-day survival similarly, 4 okay, 5, clinical frailty score of 5 starts to have a hit, down to 60% survival. And as I say, this is the mildly frail group. And I like the bottom sentence is easy. Typically, the mildly frail is progressively impairment, shopping, walking outside alone, meal preparation, housework. So many of our 80-year-olds would fit into that really very, very easily. Nice relationship on the graph there between increasing frailty score for acute hospital admissions and mortality. Not unexpected, I guess, but nice to be able to map it out properly. An interesting subset analysis looking at withdrawing and withholding of life-sustaining treatments for this group. 2 messages that come out of it. Number 1 is rather more common in the northern European countries and less common in the southern and southeastern parts of Europe. So different cultural influences, I guess. But possibly an equally important message from that. If you take it that see on the left-hand side, the none on purple withhold alone in blue and withdraw withhold in red, the withholding of certain therapies isn't necessarily a death sentence within critical care. these patients may do reasonably well and survive their hospital stay and go home. So withholding of some aspects, of some elements of care, of critical care, isn't necessarily one of saying, well, okay, this is a palliative care. It's a difference to the potential outcome. It would also make you wonder sometimes if all the investment of the critical care is actually making a whole lot of difference to that real outcome. As I say, the VIP2 study has taken place. It's closed. There will be VIP3 coming along fairly soon. Unfortunately, a smaller number of ICU hospitals, Irish hospitals, participated in it, from 7 down to 4, but hopefully that will go up again for the next study. Now, Andrew Smith was a registrar working with me at the time, and he followed up the matter data for 6 months. The study actually ran for 3 months. I thought it would be interesting to follow them up for 6 months and see what would happen in terms of frailty scale. And I'm not sure how clear it is. I just made this up recently, but the vulnerable is 4, mildly frail 5, and moderately frail 6 and above. And as you can see, the vulnerable and the mildly frail, blue being entry point, the brown colour, orangey colour being at 6 months. And as you can see, we tended to suffer a 1 to 2 point change in clinical frailty score post-ICU admission. Worse for the mildly frail than for the vulnerable. Those that don't have a follow-up are clearly those patients who passed away. It's a cohort of 20 patients. But it matches kind of similarly the earlier stuff that I showed you about the deterioration in ideate and instrumental activities of daily living at a 6 point from that previous study. So I don't know if VIP3 is going to pick that up as well, but it was interesting to me to follow through just to see. Finally, just looking at this session here, this is a nice session in Berlin. It was chaired by John Laffey. Danny McCauley was talking at it, Jeff Bellingham as well. A very nice session on precision medicine. A little bit out of touch, I realised, with the speaker earlier on, but I think it was kind of interesting to me in a different kind of way, because what worries me a little bit is we're doing all this mapping of patient outcomes and mixing and matching all sorts of age groups and coming up with different kind of concepts. And we run the risk of nearly defining patients out of ICU because they're old, rather than finding better ways to treat them. And probably we need to do both. We need to find better ways to treat really old people, but also advise and help decide what patients will not benefit. This is the VIP group research list. And without reading down through them, the ones in blue essentially are those that are mapping out detail. What are the octogenarian wishes, following frailty scores, prognostic tools, that sort of thing. But very little by way of direct interventive studies. And that's partly because it's very, very difficult to describe and to design an intervention that will work across all of Europe. So difficult to do. One at the bottom might be quite interesting, sedative and drug pharmacokinetics. So things like propofol, dexmedetomidine, etc. What's the impact upon patient dementia, which is known to impact significantly on these patients' outcomes. Maybe it's to do with blood pressure control, this one from anesthesiology, looking at mean arterial pressure and acute kidney injury. Maybe that's a focus of care. Maybe it's to do immunosenescence and our inability to rise to significant infection as we get older. Maybe it's to do with cardiovascular care and being more specific with regard to the elderly patient. But these works are not really done. And you just worry a little bit that by excessively defining that patients will do badly, therefore you will not focus on how to make those do well that could do well. Do we need to adapt our model of care? Just very briefly and in conclusion. This was presented, in fact, by Antonio Ortigas from Barcelona, but a kind of an interesting thought. Do we put enough effort into geriatric medicine and critical care combined? So do we need a whole cohort of education related to our best thing on entrustable professional activities to inform us how to deal with geriatric critical care better ourselves? And clearly this, you can see what they've picked up on here, integrating, so on the right-hand side it's more geriatric type entrustable professional activities, on the left-hand side more critical care type ones, and how they would merge in the middle. But on the right-hand side, focusing on those goals, the values, understanding the comorbidities, then what do you actually bring to them? And in truth, there's no doubt that this will bring an awful lot of investment of time and explanation and teaching of other doctors, teaching of patients, teaching of ourselves. But maybe it's a whole new subspecialty of critical care that we need to invest in, because it's not necessarily the case that we're always short of resources. It could be partly the case that we're badly using those resources by not focusing the right patients into the right beds. which is this rather interesting concept of Antonio Ortigas, and maybe it's a little bit soft on the right-hand side, but he was kind of suggesting that maybe we need to think about having a specific geriatric ICU as opposed to fitting it all into the one ICU. Now, that would certainly not work for us, but the concept isn't bad as a thinking, a level 1.5 intensive care, that kind of thought. But how do you work it out? Because it doesn't really matter. I think the whole point is we need to think about our geriatric critical care population perhaps differently and help it in a different way. Which really leads you to where we are right now. We are presented an awful lot of the time with critically ill patients who are very difficult to assess, who we haven't actually got enough data on to say, we shouldn't take you on. That's a difficult decision to make, and the data mightn't actually support your decision. We're missing two documents, or two docs normally at the start of this. We're missing the doc who understands the patient who's gone home at this stage, so you're probably finding yourself standing alone in a ward or an emergency department with a patient who nobody else knows enough about. And we're missing any documentation in terms of advanced healthcare directives or other known wishes of the patient, very difficult. So we end up engaging in a trial of ICU. Now, maybe that's not such a bad thing. Maybe a trial of ICU is okay. Maybe it's quite clever. Maybe it gives an opportunity to show that this patient has some reserve to reverse a reversible disease and go in some useful direction. But I think the middle of that thing, that the trajectory, as I've highlighted down there, is very important. I think this is possibly, certainly where I fail, and maybe others do as well, is to understand that trial of critical care really should be time-defined and to work out within a short period of time, 2 to 3 days, are we making progress or are we not? If we're not making progress, to admit that to ourselves and then to admit it to the patient and explain why. So that's the discussion points. That's what I wanted to present to you. I decided to say, well, what have I learned, as opposed to key messages? So what have I learned from listening to all these experts? Number one, we need to refine our prognostic tools. Number two, our research agenda needs to focus particularly on this age group. And number three, there probably is a model of geriatric care which we haven't really taken on board fully for critical care as yet. So thank you very much.
Nick Majerison here. Have you got yourself onto edpom.org yet? If not, you might not be aware, EdPom Chicago tickets are free for a limited period only. Go now to edpom.org. Evidence-based perioperative medicine. edpom.org.